by Dr. Aziz Abdullah and Dr. Farhan. Uh, this evening session is focusing on prostate and bladder cancer. And we have got some really good speakers who are going to cover most aspects of prostate and bladder cancer. So there is a first talk is by Dr. Johar Raza. He is a consultant urological surgeon. He was trained in Karachi in AKU and in US. He's a fellowship trained surgeon in uro-oncology. So he's going to talk about prostate cancer and he will be available for all your questions. So please write your comments and questions in the chat box and we will address them immediately after his presentation. So are we ready to start the presentation, Sharif?
Assalamu alaikum, everybody. Thank you very much, Dr. Hamad, for inviting me to present for the Karachi Urology Week, and I must commend the effort that you put in and your team in organizing this. And the ureter of the kidney. These comprise 90% of the upper tract malignancies, and they are all in urothelial origin. However, you can find variants like squamous cell, adeno, or small cell in very small percentages. You also have benign tumors that you need to watch out for. Stuff like fibroepithelial polyps, inverted papillomas, cystic urethritis, and Von-Brun's nests as well. About 5 to 10% of the urothelial cancers are upper tract in origin, with a more male predominant disease in terms of the predisposition to the gender. When you compare the stage to stage outcomes, it is similar for the disease in renal pelvis compared to the urethral upper tract urothelial carcinoma. When we look at the risk factors, smoking is one of the major risk factors, which is dose dependent, comprising of about 25 to 60% of the disease. Along with that, you can have primary bladder cancer is again an additional risk factor for upper tract disease, especially if you have multifocal NCIS within the bladder. Once you use urethral stents at the time of TURBT, you can have upper tract seeding as well. So that's another risk factor in development of upper tract disease. And about 40% patients have bladder cancer, those with upper tract urothelial disease. And that's something to watch out for when you're dealing with upper tract disease to keep bladder cancer surveillance in check. Phenacetin is an analgesic, which is off market now, but it had some alanine kind of similar composition, which resulted in upper tract recurrences. Another key thing to look out for is Lynch syndrome, and I would just spend a little time here to highlight, because this is ideal for questions and stuff, that you can find patients with 10 to 20% of those patients with Lynch syndrome can develop upper tract urothelial carcinoma. Younger men with history of family history or personal history of colon, sebaceous glands, or women with endometrial ovarian cancers do have a higher suspicion of Lynch syndrome. So at present, there are no established guidelines for these for screening, but NCCN suggests an early urinalysis and accordingly follow for microhematuria eval for these patients. So when we move on, grading and staging is much similar to that for bladder cancer. There are some differences, however. If you do not have a visible tumor, but you have positive cytology, this is kind of considered consistent with carcinoma in situ. In T2 disease, because of this thin muscularis layer, it is difficult to diagnose on biopsy or on imaging. And that also makes it more likely for, especially the urethral cancers, tumors to be more sort of advanced and do present with T3 disease rather than T1 or T2. European Association of Urology came up with this risk stratification for the upper tract tumors. It is helpful to determine if the patient can be a candidate for organ sparing management or for radical nephroureterectomy. Keep in mind, though, that the variables that have been identified for low risk, you have to meet all the variables. Management or for radical nephroureterectomy. Keep in mind, though, that the variables that have been identified for low risk, you have to meet all the variables, whereas for high risk disease, you have to any of the variables comprises it to be of high risk disease. So after risk stratification, European Association of EAU guidelines do have a nice algorithm which allows you to follow the pathway, and this is exactly what I would I can pull my pointer here. Um, so if you can see, you have um, you can see the filling defects as pointed out by the arrow on the CT urogram, delayed phase. And if you cannot perform for any reasons uh, cross-sectional imaging, then you should obtain an ultrasound along with retrograde pyelogram. And as you can see on this retrograde pyelogram film, you've got a big um, defect. I think it says 15 minutes. It may be an IVP film actually, but you would see filling defect on retrograde imaging. Now the thing is that you may sorry about this. Okay. The key thing is to know the differentials of a filling defect. It can be a blood clot, it can be a fungal ball. But that is why it is important and very, it is imperative to get a diagnostic endoscopy and get a biopsy before planning for any radical treatment. Because you don't want to be disappointed by removing a kidney for a fungal ball or big blood clot or disintegrated papilla. If you have positive cytology and a negative cystoscopy, then you should not only consider random blood biopsies, but also get bilateral selective urines for cytology to rule out the upper tract urothelial carcinoma. If you do not have a biopsy, then at least obtain a cytology from that side, because if the cytology is positive, it's highly diagnostic of CIS. The novel studies like FISH and NMP22, there is limited data available on their application, and they're only just in infancy and are very expensive test to perform. Um, Going back to the algorithm, so we are looking at the on the low risk side of the upper tract urothelial. You can do a kidney sparing surgery with the help of flexible ureteroscopy, or you can do a segmental resection, or a percutaneous approach can be employed. So when it comes to endoscopic management, it is usually preferred in low volume, low grade disease, as you can see, tiny tumors along the ureter or up in the renal pelvis and the calyces. You must make sure that it is accessible via flexible ureteroscopy, and you are able to completely ablate or remove the disease. You can choose to do laser ablation or monopolar fulguration. However, if you have a larger tumor, especially in the collecting system or in the renal pelvis, you could percutaneously approach them and perform a uh, trans nephrological resection of the upper tract tumor. When you compare the radical nephroureterectomy with endoscopic management, endoscopic management is associated with higher risk of recurrence, but there is no associated high risk of death or metastases in these patients. And this came right off the out of the press like 2 days ago, a study from Israel, which basically compared retrospective studies, small numbers, but it's a long follow-up and compared the endoscopic management with radical nephroureterectomy, and the overall survival rate was similar or comparable in both groups, along with metastasis-free and cancer-specific survival. The end of follow-up GFR or kidney functions were also comparable between the two groups. Interestingly, 92% of the endoscopic management patients had local recurrences, and about an average of 3.2 recurrence per patient, and requiring an average of 6.4 procedures per patient, which has some financial implication as if you look at it in the long run, in depending on which sort of insurance setup or payment method you're looking at. 17% of the patients required a salvage radical nephroureterectomy in this study. So, the whole idea is that you can manage low grade upper tract urothelial with endoscopic management with satisfactory overall cancer specific and metastases free survival. Then comes the segmental resection part. If you have proximal tumors, you can do primary ureterostomies after excision of the disease segment, or you can do ureterochalacostomy. You can also swing the ureter over to the other side to retain the continuity of the urinary tract. If you're looking at the mid-ureteral tumors, like I said, you can do primary ureterostomy, or if it's a longer segment, you can excise the entire segment and you can do ileal interpositioning, a very cool operation. If you are looking at distal ureteral tumors, ureteral reimplant with either Soa-Stitch or Bouary flap, and keep in mind the bladder capacity for Bouaries, can be employed to remove the disease part and salvage the system altogether. Remember to do an excision of the bladder cuff when you do the distal ureterectomy. Regional lymphadenectomy is recommended for patients who are undergoing these procedures, and they can be performed open, laparoscopic, or robotically. When it comes to the role of intracavitary treatment, BCG has been utilized for bladder cancer, and similarly, its efficacy has been reported in upper tract disease as well, comparable. However, the efficacy of the treatment of T1 and TA lesions is lower with a higher recurrence and progression rate. There is a theoretical risk of pilovenous backflow in the kidney, which may result in the higher systemic absorption of any agent like BCG, which can result in sepsis or myelosuppression from cytotoxic chemotherapeutic agent. At the moment, BCG installation in the upper tract is not advocated by any guidelines as routine management of upper tract urothelial. Usually it is done from case-to-case basis. This is something new, recently introduced. It is basically the same intracavitary treatment. Mitomycin is used in a hydrogel preparation, where it is in a liquid state in cold temperature, and it forms into a gel-like substance at body temperature, which slowly disintegrates itself and later passed on. This is instilled into the upper tract in a fluid form in a cold state, and then it warms and gelatinizes itself. Um, FDA has recently approved this for the treatment of low-grade upper tract urothelial cancers, and this was based on Olympus trial. We'll just talk about it in a second. The role of mitomycin here is not just like we do post-resection, but also it is utilizing the chemoablative properties of mitomycin as well. So this is what the Olympus trial basically looked at, and sort of it was a phase 3 single-arm prospective clinical trial in which patients had low-grade papillary tumor, at least less than 1.5 centimeter in size, and no high-grade disease. 48% tumors were unreachable by laser at baseline. So that's a very interesting fact. 6 weekly retrograde installations were performed, which was then followed by ureteroscopic evaluation, cytology, and for-cause biopsy. The primary outcome was complete response at 3 months. They had about 71 patients in that trial, and the complete response rate was up to 60%, with an additional 11% demonstrating a partial response. They did note that up to 12 months of follow-up, the complete response was sustained in about 70% of the patients. One of the major adverse events, other than some genetic issues, was about 44% of urethral stenosis, which is kind of alarming for this kind of procedure. So you have to be very careful with this. I think the best way to administer this is through a percutaneous nephrostomy tube, which is an alternative to having a stent in place or doing retrograde manipulation of the upper urinary tract. Moving on. Keep in mind the follow-up when you do an organ-sparing treatment. You have to keep an eye on the disease. If it's a low-risk disease, ureteroscopy at 3 months, and then further follow-up with the help of imaging. But if it is high risk, you may have to perform more vigilant under vision surveillance of the upper tract. Going back to our algorithm, looking at the high risk half of the algorithm, we are now talking about more extensive disease with regards to the upper tract disease and more extensive treatment, which is radical nephrouretrectomy and lymph node dissection. So radical nephrouretrectomy is a gold standard. Basically, you do nephrectomy, uretrectomy, and make sure that you get the bladder cuff excision. And this is a gold standard for high-grade disease. I won't go into the details, but you take the kidney out exactly like for RCC, mobilize outside the gerotas. You can do adrenal sparing if there's no obvious involvement. It is recommended to do an early clipping of the ureter in order to prevent a drop-down metastases of the tumor. Bladder cuff can be done with various methods. You can do it endoscopically, you can do it transvesical or extravesical approaches. Sorry about that. If you have a bladder, a tight, watertight bladder closure, then an intravesical chemotherapeutic agent is recommended to prevent recurrence, and we'll talk about that in a second. Nephro-U can be obtained, it can be performed laparoscopically, robotically, or open. When you do it open, you have to make 2 incisions, one in the flank of the kidney and the proximal or the mid-ureter part, and then a lower Gibson incision for the distal ureter and the bladder cuff. When you do it laparoscopically or robotically, you may have to reconfigure the port configuration in order to access the upper abdomen and the pelvis easily. is a bit of a controversial topic. Initially, there was no there's always been a debate about whether this is there is more therapeutic benefit to it or not, rather than just having a diagnostic or staging benefit from there. But more recently, a large population-based study did reveal that a 5-year cancer-specific survivals for patients was less for patients with node-positive disease compared to who did not have node dissection or those who had node-negative disease. However, the lymph node status itself was not an independent predictor of cancer-specific survival when a subset of population was analyzed. But within the extent of the disease, like for example, if you had high T stage or LBI, there was a staging benefit for this subgroup disease where you could identify and pick up the presence of lymph node metastases. It was also noted that patients who had lymph node positive disease, increasing the number of lymph node yield was a predictor of local recurrence, but it was not associated with cancer specific mortality. And like I said, the survival advantage is usually noted with higher T stage and complete lymph node dissection. Therefore, lymph node dissection is more recommended on a template based, and as you can see on the right hand side, a bunch of templates are reported. Martin's most recent one in Journal of Urology that looked at the templates, and basically, if you look at this side, you can identify that if you do just the hilar and retrocable lymph node dissection, but you add intra-urocable, you can increase your chances of lymph node prediction of lymph node metastasis up to 95%. So this is how they basically look at including the various templates into your lymph node dissection. And like I said, it can up to 100% of lymph node metastases can be picked up if you follow those lymph node lymphatic templates, dissection templates. If you have greater than 8 lymph nodes, it is related to cancer-specific mortality, and about it has a 75% predictability of the lymph node metastases, and that is the minimum number of lymph nodes required to declare a PN0 status. Lymph node density is another predictor which has been noted to be, if it is greater than 30%, as a predictor of poor overall survival. Moving on, let's talk about perioperative chemotherapy, neoadjuvant chemotherapy. Basically, the main aim of administering neoadjuvant chemotherapy is to utilize as much renal function the patient has in order to make them eligible for cisplatin-based chemotherapy, which they would not be afterwards. So gemcitabine and cisplatin or the MVAC regimens are available and have been reported. There is about 15% rate of PT2 disease, along with significant downstaging. A couple of trials have also reported about similar rates of success in terms of complete response with dose-dense MVAC in neoadjuvant chemotherapy in such patients. There are also immunotherapy-based clinical trials which are looking at neoadjuvant chemotherapy as an alternative for patients who are eligible to receive cisplatin for their disease management. One important thing that I would like to highlight here is the PAUS trial, which basically looked at the perioperative chemotherapy versus surveillance in the upper tract disease. It's a phase 3 randomized trial, which basically looked at patients who had nephroureterectomy with advanced stage lymph node disease, and compared them with 4 cycles of gemcitabine and cisplatin or gemcarbo if they had lower GFR, compared to just surveillance after nephroureterectomy. The progression-free survival favored the chemotherapy group with statistically, which was statistically significant. And patients who received the chemotherapy demonstrated and improved disease-free survival up to a median follow-up 30 months. 30 months. It, the disease-specific survival was about 70%. Disease-free survival was about 70% for patients who received chemotherapy versus those who received surveillance alone, which was about 50%. Another meta-analysis we recently published, which looked at the neoadjuvant and adjuvant chemotherapy. Unfortunately, there are no high level of evidence other than level 2 evidence for neoadjuvant chemotherapy, but a pooled analysis did report 11% response rate in complete response rate versus about 43% partial response rate. And when the cancer specific and overall survival were compared, it favored the neoadjuvant chemotherapy group. With adjuvant chemotherapy group, like I said, the PAUS trial and another trial from China did report there is a level 1 evidence available for that, and that also favors patients having adjuvant chemotherapy. There are a bunch of neoadjuvant and adjuvant immunotherapy trials ongoing, and we are keenly waiting to look at their results as well. So lastly, let's look at the single postoperative dose of intravesical chemotherapy. It's important that you want to limit the drop-down metastases and prevent any bladder recurrences after nephroureterectomy. There have been trials that looked at utilization of single-dose intravesical chemotherapy around the time of nephroureterectomy to prevent bladder recurrence. When the ORDMET trial looked at 40 milligrams of mitomycin versus standard of care in these patients, and the recurrence rate was about 16% in treatment arm versus 27% in the control arm. The absolute risk reduction was about 11%, and number needed to prevent one bladder tumor recurrence was 9. So if you do instill chemotherapy in 9 patients, one of them will not have, in order to prevent one recurrence, you have to treat 9 patients. This intravesical installation is recommended. It can be gemcitabine or mitomycin, whichever is available. And it is usually administered before the removal of Foley catheter. Some people do it at the time of the surgery when they see that there's no obvious leak. Some people choose to do it at a delayed time, more at the time of the cystogram, when they have, radiologically ruled out any bladder leak prior to installation. So in summary, for upper tract disease, ureteroscopy biopsy is the key in diagnosis. Low-grade and low-volume disease can be managed with nephron-sparing approach. Neoadjuvant chemotherapy is about 11 to 14% response, complete response rate, so it should be considered, especially prior to loss of renal functions and in patients with high-grade and high-risk features of the disease. Template-based lymph node dissection should be performed because of improved staging benefit, and may have some potential role in therapeutic and prognostic ways as well. Adjuvant chemotherapy, we have level 1 evidence that it improves outcomes for the patients with advanced disease, so that should be offered to all patients. A single installation of mitomycin or gemcitabine should be performed perioperatively to reduce drop-down metastases and bladder recurrences. Again, remember, 40% of the upper tract disease develops bladder cancer, so please do not forget to survey the bladder and keep it under your close check. Thank you very much, and maybe we can switch to questions in a second.
Dr. George, there are a few questions in the chat box.
So the question is, should we do ureterostomy in proximal ureter cancer as if we are anastomosing diseased ureter to a normal ureter? So if I'm understanding correctly, you've already done a ureteroscopy and ruled out any obvious disease. So in that case, obviously you have to make sure that when you do this, there is no obvious disease left. And that's why I think if you go back to the surveillance part, it's important to survey these patients in order to make sure that there is no disease recurrence. And another reason why the endoscopic management trials have got, or studies have higher rate of recurrences, is probably because it's a field change disease. So yes, you can. Again, it depends on the volume of disease and the grade of the disease. If you have low-risk tumors, lymphadenectomy, is it needed? You can argue that. I don't think you should do a dedicated lymph node dissection in those cases because your imaging will probably be directing that. Ironically, having one of the trials, one of the studies reported a high positivity rate for or prediction with even just 2 lymph nodes. So probably for it was for high risk disease. So in case of low risk disease, you could consider omitting lymph node dissection. Anything else? I'm sorry, my talk ran over the time limit, but once again, thank you very much for allowing me to participate. And maybe I can put my email address in the chat if somebody wants to send questions out or need anything else. There's we can do. That's a good question. Is there a safe margin limit? There is no safe margin limit as long as you have visually negative disease. To be on the safe side, yes, you can send a frozen section. That will make it more comprehensive in terms of your operative comfort that you've taken out the disease segment. Yes, I would recommend a frozen section. Nope, I just send it to Bushra. Send it to everyone.
Thank you, Jawahar, for your nice presentation. I am Dr. Abdul Hafiz. So I think I should, I think I should proceed for my presentation.
Yes, please. Sorry, I took you 5 minutes. Go ahead.
I want to share my screen. Can you see my screen?
Yes, sir, we do.
So should I proceed, Sharif?
Thank you.
I am visible to all or not?
Yes, sir, you are visible and your presentation is also visible, sir.
Okay, thank you very much for giving me the chance to present one of the interesting topic that is what the current guideline says about the cytoreductive nephrectomy and the metastasectomy. So before going to my presentation, I would like to give you that at the end of my presentation, the participant would be able to understand what is the cytoreductive nephrectomy and the metastasectomy. And at the end, they will be able to select the patients who needs cytoreductive nephrectomy and metastasectomy. And the fourth one is the literature review about the cytoreductive. And at the last, I would talk about the guidelines. So everyone must be aware about the theory, but I would be more interested to look the stage 4 disease, that the patients who have whatever the T stages, but have the synchronous metastatic lesion in the body. So by looking the definition that the cytoreductive nephrectomy is the removal of the primary tumor in the presence of synchronous metastatic lesion, while the complete metastasectomy is the surgical resection of all clinical evident metastatic disease. So before going to the detail, I would like to give certain introduction about the metastatic RCC, that we don't have any the correct statistics about the Pakistan, that this data is from the US, that approximately 16% of the patients who have the renal cell carcinoma, they present with the metastatic disease. And by looking the overall survival, that is about the 12%, but it depends upon what the category of the patient is, either it's a favorable, intermediate, or the poor risk. So in the last many years, the lot of advances has been done in the management of the metastatic RCC. That is the patients who have the metastatic disease, they started with the cytokine therapy till the immune checkpoint inhibitors. So those patients who have starting from the cytokine therapy, because the start of the metastatic treatment, the patients who before the 2006 they started with interferon interleukin 2, but by looking the toxicity of this treatment, that has been now obsolete. By looking the randomized control trials has been done in the 2000 the patient who have the only cytoreductive nephrectomy along with interferon alpha, that the patient who have the cytoreductive along with interferon have the good overall survival. So with the last many years, now the advances in the medical treatment of the metastatic RCC, there is immune checkpoint inhibitors which targets the PD-1 and the PD-L1 and CTLA-4 pathway. So yes, whatever if the patient who comes in your clinic with a metastatic RCC, you have to select the patient accordingly. So there are certain factors by looking the patient, one starting from the patient point of view, that the patient, we always categorize the patient by looking the IMDC or MSKCC criteria. So this is the risk factors for which we can categorize the patients into favorable, intermediate, and poor risk categories. So always remember that whenever the patient who comes in your clinic with and you have diagnosed that it's a metastatic RCC, then you have to look these three the things in your mind. One is the patient, other is the disease, and third one is the health facility what available you have. Coming towards the categorization of the patient, which is either by the MSKCC or IMDC, which is International Metastatic RCC Data Consortium. So these are certain things which you have to look in the patient, like starting with these criteria. And second thing, which is here, which I will point out, that performance status is very important to the patient, because the patient who have the metastatic disease, you have to always look the performance status. The patients who have the good performance status, they will bear the major surgery along with the metastatic lesion excision. And second and third thing in the patients, the symptoms. Obviously, the patient who have the metastatic disease, usually they have the symptoms like have the hematuria, or the patient with the compression symptoms. So you have to look the symptoms of the patients. Number second is the tumor per se. So whenever the patient who have the tumor, you have to look certain factors in the tumor as well. So starting from the thrombus, either the patient who have the presence of the thrombus or not. So the patient who have, there is a promising data that shows that the patient who have the thrombus, which is infrahepatic, and the suprahepatic. So the patient who have the level 4 thrombus, which is a supradiaphragmatic, obviously have the very poor prognostic factor. So these patients are not ideal candidate for the cytoreductive surgery. Coming towards the second point, which is a metastasis, obviously the number of the lesions and the location is very important. So there are a lot of data regarding the location of the disease. The patients who have the single lesion or oligometastases in the lungs always have the better prognosis than the lesion in the brain or the bone. So again, this is the location is very important. Number third, if you have the pre-surgery, you have the biopsy, like a clear cell or the non-clear cell or sarcomatoid differentiation. Obviously, sarcomatoid differentiation have the poor prognostic factor, that because if we look the literature, that many articles have published the presence differentiation is a prognostic indicator for the survival in a surgical treated metastatic RCC. So the data is published in 2017 and 2020 as well. So the sarcomatoid differentiation, if you have the pre-surgery, you have the biopsy, obviously this is have the poor prognostic factor. And the last one is the tumor size. If the tumor size is more than 4 centimeter and the less than 4 centimeter, which have also impact on the patient, the survival. And the last one is the system. System means the hospital volume, like the people who are coming in the tertiary care setup, which have the all facilities of this better surgery, number one, and number two, the patient who are the hospital have the expertise and the experience of the patient who are dealing with these metastatic lesions. So obviously with the time, with the experience, they have the good surgical outcome of the patient if those patients are treated in that tertiary care hospital. And then the third thing is in this that the patient, the hospital should have the multidisciplinary approach. So these patients should be, whenever the patient who comes in your clinic, these three factors you should keep in your mind when you were thinking about going for cytoreductive surgery. So this is the algorithm of the patient who comes in your clinic. Then you have to start with the basic workup, starting from the complete blood count, then the metabolic workup, then the radiological like the CT chest, abdomen, the pelvis with contrast. So you have to look where the disease is, either it's presence in the eye or the oligometastases or the single lesion or the all over the body which is infiltrated with the lesion. Then coming towards the bone scan, looking for the MRI brain, and if you have the plus minus biopsy. So this is the starting from the stage of the disease, you have to stage the patient. Then second line, if you evaluate the patient by looking the prognostic factor. As I already discussed with you that you have to categorize the patient with the risk category by either doing the IAC or MSKCC criteria. Then in which you can see there's a hospital, it's very important that you have to look the multidisciplinary team should be there. So and on the left side, you can see in this algorithm that the patient who had the favorable or intermediate risk category, they are usually ideally candidate for going for the cytoreductive nephrectomy on the left side. By looking again the performance status, which I already discussed about it, the patient who have the limited metastatic lesions, like the patient who have the single lesion or the oligometastases, or even the location of the lesion is very important. And looking for the symptomatic primary tumor. So these are the patients who are ideal candidate, which can be can go for the cytoreductive nephrectomy. So there are a lot of data which is available, and almost all the studies are the retrospective studies that has compared with the patient who have the cytoreductive and without the cytoreductive. They have the follow. And if you look the overall on the right side at the slide, you can see the overall survival in the patients by looking the hazard ratio, which is almost less than 1 in around 80 to 90% of the patient. So that shows that the patient who had the cytoreductive nephrectomy had the overall survival is better than those who haven't. So looking at the certain systemic review has been published in the 2019 in the European Urology that shows that in which they look the patient who compared with the cytoreductive versus no cytoreductive, and they assess the overall survival in the patients who have the metastatic disease. So they look that the nephrectomy is a still role in the patient who have the limited burden of the metastases. We already discussed about whenever you think about the patients who need the cytoreductive surgery, and those who have the small lesions or single lesion or oligometastases, and also by looking the other factors, they're usually the patients who are candidate for going for the cytoreductive surgery. So you can look the another article which was published in Journal of Urology in 2004 by looking the cytoreductive surgery in a patient with the metastatic RCC. They basically divide the patients, 331 patients, into two identical protocols, and they look the cytoreductive nephrectomy plus interferon and interferon only. So if you look the patient who have only treated the systemic therapy, they look the primary endpoint was the overall survival, and the second endpoint they look the response rate in the patients. So the pre-randomization, they look the performance status of the patient, they look the site of metastases, and they look the disease measurability. And at the last, they looked that the results were the median survival was 30 months in cytoreductive along with the interferon, and those who have only the interferon alone, they had the low overall survival. Coming toward the cytoreductive nephrectomy again, that the patient who had the complete metastatic removal of the disease or not. So it's institutional experience that they shared with the cytoreductive alone, the cytoreductive with the metastasectomy. So they looked the data from 1989 till 2003, that they looked the median overall survival for the patients who underwent the cytoreductive surgery plus metastasectomy was 30 months. But if you compare with the cytoreductive nephrectomy only 12 months. So there was significant difference between the patient who had the cytoreductive along with metastatic lesion excision. So another looking the article which was published in European Oncology in 2019, they looked the surgical metastasectomy in RCC. It was again the systemic review. They looked the median overall survival in the patients. It was around 36 to 142 months, those who had the surgical excision, while which compared with the 8 to 27 months who didn't have the surgical excision. They looked the what were the important prognostic factors in a patient who have the good overall survival was the complete resection of the metastatic lesion. So this point is very important when the lesion are amenable for the complete resection. Ideally the patients, and also you have to consider the other factors like the patient factors, which I described you in a triangular diagram. That this is also very much important. So they look other factors as well, like tumor size, sarcomedoid features. They look for this number of metastases and also the performance status. Almost all the same things which are I described you in a previous slides. That these are the very important things. So coming towards the isolated liver resection, if the patient who have the solitary lesion in the liver, and they showed about the 12-year retrospective study published in one of the article version of urology, that they looked the lesion by comparing the patients who didn't have any surgical excision of that liver lesion. So they look about the overall survival of the patient at the 5-year after metastasectomy was 62% in a patient, and they had about the median survival was 142 months. But if you compare with the patient who didn't have the surgical excision of the metastatic lesion, they have only 29% with 27 months. You can see on the right side the Kaplan-Meier curve that shows the upper line, which shows about the patients who have around the 60% the 5-year survival rate, while the patient who have around the 22 or 26% survival rate, the patient who didn't have any surgical excision of the liver metastatic lesion. Coming towards the isolated, the pancreatic metastatic lesion, the patients who have the RCC, metastatic RCC, there were a retrospective study. They looked about 36 patients who had the pancreatic lesion, and they looked the data about 1998 till the 2006, around 18 years data. That they looked at 23 patients, they did the following surgeries, like 11 patients had the distal pancreatectomy, and 5 had enucleation, 4 had pancreatectomy, 2 had the complete pancreas removal, and 1 had the middle pancreatectomy. So they looked at the 5-year actual survival rate, which was 88%, and the median disease survival was 44 months. But the patient who didn't have any surgery, the 5-year survival was much lesser, which is about 47%. So this is also suggests the data that the surgical excision of the pancreatic lesion have the good survival. Coming towards the lung metastatic lesion, if you look the metastatic lesion in the body, the lung metastatic lesion have the better prognosis over the metastatic lesions, because there are a lot of data suggest about the metastatic lesion in the lung have the favorable outcome if you are doing this complete surgical excision. So it's one of the most frequent site, as we know, because there are the main frequent site of the RCC, metastatic RCC. Number 1 is the lung, number 2 is the liver, and number 3 is the bones. So these are the mainly 3 lesions, 3 sites for the common sites for the metastatic RCC. So this is the retrospective study that was done from the 2000 to 2016, about 16 years study. 27 patients who underwent the pulmonary resection of that lesion, and they looked the outcomes and prognostic factors which were associated with survival of the complete pulmonary resection, and they looked the 5 to 10-year overall survival was 75% and 59% respectively. They again looked the what were the independent prognostic factors for the survival. They looked the dimension, it means the size of the lesion, which is more than 2 centimeter, and they looked the disease-free interval in a patient which is about the 5 years. So the only independent prognostic factor which was affecting the disease-free interval was the dimension, it means the size of the pulmonary lesion. So now come towards the NCCN guidelines. What the guideline says about it, because we have seen the literature, I have just described you how you proceed the patient who have the metastatic lesion. So looking the 2021 guidelines, NCCN, what the NCCN says. So here I would like to give you, because the talk on the stage 4 disease. So the stage 4 disease, it means that whatever the T is, but the patient who have the synchronous metastatic lesion. So if the potentially surgically resectable their disease, which I told you either it's oligometastases or the single lesion, then you can go for the cytoreductive nephrectomy in selected patients. So this is again, in every slide there is selected patients. Not all the patients are the candidate for going for the cytoreductive surgery. So again, if you have the clear histology or you have the recurrence of the disease, you have done the primary surgery, you have done the radical surgery for the patient, and after the 6 months, after 1 year, you have a single lesion, you have a clear histology, obviously you should go for the metastasectomy. Again, looking for the non-clear cell, the NCCN says the metastasectomy have that role. Coming towards the EAU guidelines on the renal cell carcinoma, what the EAU guideline says about the cytoreductive surgery. So you can look at the cytoreductive nephrectomy in a patient who have the simultaneous complete resection of a single metastases or oligometastases may improve survival and delay the systemic therapy. So at the last, at the conclusion, we have now well aware about what is the cytoreductive surgery, what is the metastasectomy, and there is a significant evidence that shows the cytoreductive nephrectomy have the benefit in the patients who have the management, symptomatic management, and survival standpoint of view in a selected patient again. And selection is nuanced process. Decision making with the patient is very important, and multidisciplinary setting is very important. And there should be some experience with the urological surgeons and medical oncologists. Thank you so much. These are the teachers from which I have learned a lot. Professor Hamad, Professor Zafar Zaidi, Professor Hassan Labin, and Professor Vichas. Thank you so much. This forum is open for the questions.
Thank you very much, Hafiz. I think you have very comprehensively covered this difficult area, which has been issue of contention because of the lack of good quality systemic treatments. And but I think you have done justice to the job, and I hope that it must have cleared a lot of concepts. What I'm going to now do is to present some cases, and we're going to discuss in the light of what has been described by Dr. Hafiz. And although not all cases are metastatic, there will be some localized things as well. So we're going to look at some of the interesting cases so that the concept of management of small versus large versus metastatic cancer is understood. So again, it's going to be interactive session, and I would like you guys to be involved in this and cast your vote on a timely fashion. Okay? Can you all see my screen?
Yes, we can see.
Okay, thank you. Okay, I think I have to go on to full screen. The CT scans are visible on the screen? No.
No, sir, CT scans are not visible.
Okay. CT scan, we can see only the case.
Yes. Is it visible now?
Yes, sir.
Okay, thank you very much. Okay, so let's start with the first case, and this is a 66-year-old controlled hypertensive patient who is diabetic, history of ischemic heart disease, incidentally diagnosed with a solid renal mass on an ultrasound, and subsequently had a partial nephrectomy. And it was a clear cell carcinoma, T1A, which means that it was less than 4 centimeters. His preoperative creatinine was 1.4. However, his postoperative creatinine is 1.5. And this is a preoperative scan, and you can see in the non-contrast scan, there is a suspicion of a lesion on the upper pole laterally. And then this is the corticomedullary phase where you can see an uptake, whereas in the nephrogenic phase, you can see the contrast uptake by this tumor. And it was removed with a clear margin. I didn't do any frozen section because it came out nice and clean. And so my first question to the participants, and Sharif can share the poll, is that should CT chest be done in the preoperative staging of this patient with T1A lesion? And you can vote now. Okay, so I think more than 50%, nearly 60% have voted. I'll just wait for 3-5 seconds more for anyone else who would like to vote now. Okay, fine. So, well, we are head to head with yes and no's. And one person has said it's optional. So let's see what the guidelines suggest. So before we go on to the guidelines, one more question. What imaging to use to detect the disease status in the post-operative surveillance? So this patient is now, say, 3 months post-operative, and he had a partial nephrectomy for a T1A tumor. What would you do in the post-operative follow-up? Remember, his creatinine jumped from 1.4 to 1.5 in the post-operative phase. Right, that's going well. More than 2/3 have voted. I'm going to end the poll now. And there is a clear thing that this patient should have a contrast CT. Now remember that contrast MRI is more dangerous than contrast CT. So contrast CT, we have significant experience by increasing hydration, giving patient an N-acetylcysteine preoperative, pre-CT, 1 dose, pre-contrast, 1 dose on the day of CT, and 1 dose after, 1.2 grams, either intravenous or in the oral sachet format. And that decreases the contrast-related nephropathy significantly. The other thing is that we monitor their hydration, and this way we can decrease the chances of the contrast-related nephropathy. However, the nephropathy that can result from MRI contrast is very significant, and it is at times irreversible. Does anyone know what is that nephropathy called, which result from MRI contrast? And the MRI contrast is gadolinium. Anyone? It's called nephrogenic systemic fibrosis, and it can result in irreversible damage to the kidneys. Okay, so if you have any concern about kidney function, contrast MRI scan is totally out. There are new modalities like contrast enhanced ultrasound, which is by introduction of microbubbles, And that is something that can be done. A non-contrast MRI is also an option. An ultrasound done by an experienced person is also an option. So if you look at the guideline suggests that you don't need to do a CT chest in patients who have an incidentally diagnosed T1A disease. Sorry about this. So CT chest is not needed in the preoperative evaluation of these patients. The second question that we asked is about the use of postoperative imaging in T1A patients. And the guidelines suggest that non-ionizing modalities, including MRI without contrast, contrast-enhanced ultrasound, are better modalities than contrast CT if you have any concerns about contrast nephropathy. And this patient is at risk of contrast nephropathy. Okay. So this is the agents which are used for contrast-enhanced ultrasound. And these are various types of agents which are phospholipid shell or albumin shell, and octofluoropropane is the agent which is used, or sulfur hexafluoride. Unfortunately, these are not available currently in Pakistan, so I don't have any personal experience with the contrast-enhanced ultrasound. But the data suggests that in good hands, contrast-enhanced ultrasound can actually even differentiate between oncocytoma, although oncocytoma and angiomyolipoma from RCC. So that's one thing that can be for future once we have greater experience. We move on to the second case. And this is a 46-year-old lady who had an incident. She's a school teacher. She had an incidentally diagnosed solid renal mass, as you can see very clearly on the left lower pole. She had microscopic hematuria, her creatinine is normal. She's planned for partial nephrectomy. However, she's concerned about the overall prognosis, and she is asking what her chances of complete tumor clearance after this procedure. So we need to give some objective answers to her. And these objective answers can be from data. So my next question is, and poll number 3. Right, so you can vote now. The question is, what are the important clinical prognostic factors in assessment of the patient that we have discussed? So is it the tumor TNM stage, tumor size, tumor grade, RCC subtypes, or all of the above? So wonderful. I think almost all of you are getting involved in the polls now, and I expect you guys to continue with the trend and keep voting. So I end the poll now with 80%, and vast majority of you think that all of the above, and I agree with that this is the correct answer, that all of the above are important in the prognosis of patient with RCC. The next question is that grading is important, and the grading system are 2. One is the Fuhrman's grading, and the other one is the new WHO International Society of Uropathology grading. Which one should be used in patients with the RCC? Okay. I end the poll now and share the results with you guys. Well, it's neck to neck between the 2 grading systems. We know that the Fuhrman's grading is something that we have used for a long time. And this Furman is now replaced by the new WHO International Society of Uropathology consensus grading system, which has been operational for the last 5-6 years. And this is something that we use now. So ideally, if your pathologist is comfortable, he or she should do the WHO ISUP grading system rather than the Furman's grading, which is no longer conventional in the world. So the next poll, okay, so the next question is that should prognostic models be used in patients with RCC? Should they only be used for localized and metastatic cancer or only in the metastatic settings? Okay, I'm ending the poll and share the result with you guys. Majority of you think that they can be used for both metastatic and localized settings. So you are right. Although it's more frequently used for the metastatic setting, and we know that the IMDCC is the system which is most frequently used for this. So the Sloan Kettering Memorial System is being replaced by IMDCC, which should be used in the metastatic setting, but they are models available for localized disease as well, and they can also be used. So I think both answer I would consider correct. Let's look at the guidelines, and the guideline says that in RCC patient, TNM stage, tumor size and grade, RCC subtype provide prognostic information. So all those of you who voted for in favor of all the above are right. Well, the WHO ISUP grading system is the modern way of classifying or grading renal cell carcinoma, and it should replace Furman. So ask your pathologist if they are still using Furman system to please switch to the modern system. And prognostic models be used for localized and metastatic disease both. Molecular markers have no role in the current evaluation of patient with RCC. They are only for trials and studies. Okay. So I think so far so good. Things are clear. Let's move to the next case. Now this is a 58-year-old male who is hypertensive for the past 10 years, a smoker. He is a huge man. He is over 140 kilograms, I think more than that probably. And he could hardly fit our table. Obviously, he has obstructive sleep apnea. He also has depression and has been on antidepressants. He presented about a year back. No, he has since 1 year abdominal distension. And since he's got a huge tummy, he was able to store this huge tumor in his tummy without any significant problems. So as you can see, that you can see a bit of a normal upper pole and bit of a normal lower pole. And this is a huge circumscribed tumor in the right kidney, which is pushing the IVC laterally, and it was clearly adherent to the IVC. However, it is clear from the liver and posterior abdominal wall as well in the lateral sagittal cuts that we have seen. But this was a huge tumor. the oncologist actually has been seeing him, and they have recommended, he also had a chest CT, and I'll show the chest CT. This is the chest CT, and you can see there are nodules in the chest, multiple nodules in the chest. They first tried to biopsy this RCC, and they've done it ×2. However, they were not able to get the material for clear histopathological diagnosis, because as you know, that histopathology type is important in deciding about the systemic treatment for RCC. So the patient was presented in the tumor board, and the tumor board consensus was that if possible, this tumor should be removed and do a nephrectomy, and then we can have some pathology, and subsequently we can treat him with medical treatment based upon his pathology. So he underwent a radical cytoreductive nephrectomy, to be honest. Was a huge mass, and although we opened him up with a midline abdominal incision, we still had a lot of difficulty in removing this mass with a huge from epigastrium to symphysis incision. This mass would come out with a lot of difficulty. And the most interesting thing is that after the surgery, when I went outside and counseled the family, one of the family member was a physician. She said, "I'm a physician, I'm a doctor." So I said, "Fine." And she said, "Doctor, why you have not done this procedure laparoscopically?" So I don't know how to answer that question, okay. But anyhow, so we removed this tumor with the help of our vascular surgeon, because the IVC was very closely adherent to this tumor. It was removed, and we were able to do a clean resection. The pathology came out to be papillary type 1 RCC, and not a clear cell RCC. This tumor was about 24 centimeters in length, and the rest of the features were, as you can see here. And you see that this is a nice pathology report, which not only look at the tumor focality, it was a unifocal tumor, as you can also see on the CT scan. The histological type to see if there is any sarcomatoid features, which is one of the risk factors. Rhabdoid features, again, a significant risk factor. The tumor necrosis, the WHO grade. See, this is the WHO grade, the ISUP grade, which I was talking about. Microscopically, it was limited. The margin status, all the margins need to be defined so that we know that we have done an R0 resection. And although this is a metastatic disease, the lymph node was removed, and the lymph node metastases was also not observed. So this was it. Okay. Let's move on to the next case. And this is a case of a 30-year-old female who presented with menorrhagia and was undergoing workup of fibroid in the uterus with a CT scan. And on examination, she was markedly obese. She had she was although a functional class 0, and the rest of the examination was unremarkable. This was her CT scan, and this CT showed about 6.8 centimeter upper and mid-polar renal cell carcinoma, and the features were a bit confusing, because if you look at these markings that sometimes give you an impression it could be an oncocytoma. But because of the local extension and spread of the tumor on the posterior abdominal wall, the impression was that this is an RCC. Because it is a T2 disease, nearly T2 disease, she also had a CT of the chest, and the CT chest showed one suspicious lesion in the right lung. So this is what it is. So an obese, middle-aged lady with 7 centimeter, nearly 7 centimeter RCC with a suspicious nodule in the lung, and the rest were all okay. So my question, we go to the next poll. How should she be considered? Should she be considered for partial nephrectomy? Can we have the next poll? Or she should be considered for radical nephrectomy? Should we do a bone scan or a PET scan first before further decision for treatment? So if she comes to your clinic, would you consider her for partial? And obviously you take a consent for partial / radical. Or you should do a radical straight without attempting partial. And or would you first do a complete metastatic workup before you consider her for surgery? So for a T2, would you consider doing a bone scan and a PET scan? Or just a PET scan? Right. So more than about 2/3 of you feel that she should be offered radical nephrectomy. So this is the result, and more than 60% think that she should have a radical nephrectomy. Let's see what the guidelines suggest. Before we go on to the guideline, another similar case, a 56-year-old male, controlled diabetes and hypertension. He's a landlord, he's a smoker, occasional alcohol, creatinine of 1.5, and a hemoglobin A1C of 10.3. Hematuria with clots for the past 3 months, and the CT showed a 7.2 centimeter left lower polar mass with no lymphadenopathy. And the rest of the CT scan was fine, and there is no other disease as such. So there is no metastatic disease. His chest CT was also fine. Would you consider this gentleman, can we have the next poll, for radical, partial, or you would like to do a biopsy first before you would intervene? So the next poll, please. You can vote now. Okay, most of you have voted. So I'm going to end poll and share results with you. And as you can see, that majority is in favor of a partial nephrectomy, whereas about 40% says radical nephrectomy, and one of you thinks that a biopsy be done first. Well, I think this is a clear single unifocal without node or metastatic disease cancer, and surgical treatment is the treatment of option of choice. Even if it comes out to be a oncocytoma, probably surgery is the way of going about. So biopsy probably is not indicated in this case. But yes, radical versus partial nephrectomy is debatable. And we will look into the guidelines to see what they suggest. Essentially, what you can see is the difference between the last patient and this patient, and the difference in the poll that we saw. Majority favored radical nephrectomy for the last patient, and majority voted for partial nephrectomy in this patient. The difference is probably that there's a suspicious metastatic deposit in the lung in the first patient and nothing in this patient. So let's see what the guidelines recommend. So the retrospective study suggests that oncological outcomes are similar for partial versus radical nephrectomy for tumors which are equal to or more than 7 centimeters. So our cases fitted into this category of one of them was about 6.8 and the other one is 7.2. So they are about that much. Indeed, the postoperative complication rate is slightly higher for partial nephrectomy if you do it for T2 cancers. In patients with localized disease without radiographic evidence of lymph node metastases, a survival advantage of lymph node dissection in conjunction with is not demonstrated. So the quality of evidence is not high. These are 3B and 2B level of evidence. So really no clear RCTs is available to make a judgment. Well, the recommendation, although because based upon 3B and 2B recommendations is weak, that offer partial nephrectomy to patients with T2 tumor, particularly if they have a problem with the other kidney. And since we know that the landlord gentleman was had poorly controlled diabetes and his creatinine was also on the higher side, probably he would be better off saving as many nephrons as possible in that setup. Okay, so I hope so far we are clear and there are no further questions. Let's move on to case number 6. Now this was an interesting young surgical resident. This lady presented to the emergency room and some of my residents probably would remember her. Is a 46-year-old surgical resident who presented with acute flank pain and urinary tract infection. Her ultrasound was done on her advice or on her request, and it showed a suspicious lesion on the in the right upper pole of upper pole of the right kidney. CT was subsequently done, and as you can see in the CT scan, that she has a definite mass in the upper pole of the kidney. And she is basically considering and wanted to have lap partial nephrectomy. So the question is that what are the advantages of lap over open partial nephrectomy? Is it better oncological outcome, better functional outcome, fewer immediate postoperative complications, or none of the above? Okay, so I end the poll now and share the results with you guys. So this is the outcome, and you can see that the 40% thinks that it is better functional outcome, 40% thinks that there is fewer postoperative complications, whereas 16% as minority think that there is no advantage or no significant difference in terms of oncological outcome, functional outcome, and immediate postoperative complications between lap and an open nephrectomy. Okay, so I counsel her and I say that I don't do lap. So if she wants to get it done from somewhere else, I would suggest a good center, because lap partial for this kind of tumor is a significant undertaking. See, she opted for open, and I did an open partial nephrectomy. And if you remember the CT scan, there is a little parenchyma here, which is separating this from the renal pelvis and the hilum. And this is a clear part endophytic, part exophytic, about 50% endophytic plus 50% exophytic tumor. And when I did a nephrectomy, I did basically an enucleation of the whole, and as you can see, that the whole thing came out as one piece without any capsular breach. However, I was a little suspicious about that rim of parenchyma. And once I removed, I took that rim of parenchyma as well. Fortunately, that didn't show any in the frozen section, and subsequently on histopathology that there was no disease in that rim, and I could have probably left it, but I just want to be extra careful. And so she had a complete clearance, no positive surgical margins, and she's, I think, more than a year after surgery, and she's disease-free. This is another patient who had a significantly endophytic and almost all completely endophytic tumor here. And again, we did an open partial nephrectomy, and it is almost impinging upon the hilum. We were able to take it out clear. However, once we took it out and the frozen was negative, but this patient has a positive surgical margin, as you can see, that there is positive surgical margin. So our next poll is focusing on these two cases, and I'm going to pose questions one after the other for your consideration. Next one, please. So if you have positive surgical margin, how would you manage this patient? Would you do an immediate radical nephrectomy? You do a redo partial with frozen section, and if the frozen section comes out positive, do a radical. You do active surveillance or start systemic treatment. Okay, so let's end the poll now, and I'll share the results with you. And I'm really happy with the opinion of our delegates, and that active surveillance is the way to go. Now, there is very good data indicating that positive surgical margin after partial nephrectomy is not an indication of immediate nephrectomy. And I'll just share some of this data before. So this is the EAU guidelines that about the first question that I asked about lap or robot assisted versus open. Well, there is to be evidence that robot assisted or lap partial nephrectomy has shorter hospital stay and less blood loss. So it is better in terms of immediate post-operative things. But by and large, there is no functional and there is no oncological advantage of one over the other. Radical nephrectomy after positive surgical margin can result in overtreatment in many cases. So active surveillance is what is recommended for such situations. So intensify follow-up in patient with positive surgical margin. So do it more frequently and more extensively than you would have done otherwise. Barring that, you don't really need to do. So if there is an alert, then the treatment is indicated, but not immediate partial radical nephrectomy. So I have about a few more minutes, so maybe one or two cases, and then we'll wrap up. So this is a case number 8, a 78-year-old lady, known case of diabetes and hypertension, had an ultrasound for microhematuria, showing a small solid tumor. As you can see, this is an ultrasound which is showing a solid lesion here. This is the CT scan, which is showing essentially the same thing. The question to you guys is there a size limit? Should you treat this by, obviously these small renal masses are treated by either partial or by cryoablation or by active surveillance. So the question in the next poll is that, is there a size limit for use of thermal ablation, which is microwave or RFA or cryo? Is the size limit different for RFA versus cryo and microwave thermotherapy? So, I mean, in this situation, essentially, there is not one correct answer, but there is best correct answer. One of it is a best correct answer, but one of the other answer is also correct. Okay, let's end the poll. And I think this is a very good response from you guys. And yes, there's no doubt that there is a size limit to it. And that size limit is different from RFA to cryoablation. So when you're doing thermal ablation, should you take a biopsy first? Next poll, please. Do biopsy at the time of thermal ablation and do thermal ablation irrespective of the result, or do biopsy prior to ablation and wait for histopathology? Okay, so I end poll now, and let's share the results with you. So majority of you think that a biopsy should be done first prior to and wait for histopathology and then decide whether thermal ablation is needed or not. Let's look at the guidelines. There is a low quality evidence which suggests that disease recurrence rate after radiofrequency ablation of tumors greater than 3 centimeter and after cryoablation of tumors greater than 4 centimeters. So there is a different cutoff for cryo and RFA. Low quality evidence also suggests that higher recurrence rate after thermal ablation therapies compared to partial nephrectomy. But again, these are low quality evidence, as you can see that these are level 3 evidence. So the recommendations are that active surveillance or thermal ablation can be offered to frail and elderly people because the growth rate of small renal tumors is extremely slow or low. It is not more than 1 millimeter per year. So you can easily do active surveillance for elderly people who are incidentally diagnosed with there is a strong evidence in support of performing a percutaneous biopsy first and then going for thermal ablation rather than doing it simultaneously or not doing it. Right. So my time is over, so I'll stop at this point, and I'll see if there are any questions or comments. Well, systemic nephro, I don't know what does that mean. There is a comment that deferring the immediate radical cystectomy has very weak evidence. Patient should not be left with positive surgical margin. Can this lead to legal issues? I don't think that this comment is right, but I understand that the you cannot conduct a randomized controlled trial on patients who have surgical margins positive and treat one group and not treat the other group. But the current data that we have, and decisions are made on the current data, not evidence-based, high-quality evidence available for majority of surgical conditions, unfortunately, is that the growth rate in terms of patients who've got positive surgical margin is low, so they can be observed, and if there is any evidence of disease recurrence, then you take a decision. Okay, so if patient persists for redo, the patient, if the patient insists that no, they want to have that kidney removed, or they want to have a redo partial nephrectomy, that's a different situation. Well, you can explain to them that this is not really favored in current guidelines, but that's one thing. So remember, the guidelines are recommendations. Guidelines are guide. They are not the world on a holy grail, so you don't have to go exactly how the guidelines suggest. The guidelines have to be modified according to the local circumstances, according to the availability of resources, the expertise, and so on. So guidelines are based upon published experience in light of the recommendations coming from the expert panel when they evaluate the evidence. And so this is not the last word. So these are only recommendations. You can, if there is a better evidence available and you make decision based upon that, that's fine. So right, thank you very much for your attentive listening, and I'll stop sharing my, and I would like to introduce our next speaker, who is Dr. Mr. Naved Afzal. He's a consultant urologist in Dorset. He has been a big supporter of our academic activities. He has special interest in robotic prostate surgery. And his talk is focused on clinical decision-making in organ-confined and locally advanced prostate cancer. So, Mr. Afzal, thank you very much for being here this evening for our Karachi Urology Week. Please proceed.
Good afternoon and assalamu alaikum to everyone. I'm very honored Professor Hamad has asked me to give a talk on localized and locally advanced prostate cancer management. So I'll keep this talk as brief as I can. Okay, so starting with a little bit of prostate cancer is the most common, second most frequent cancer, and 1.3 million new cases diagnosed every year, fifth leading cause of death in men, and around 360,000 deaths worldwide. That was statistics from 2018. And again, my practice based in UK. So is most commonest male cancer in UK. For nearly 40,000 men are diagnosed every year. 11,000 people die every year with prostate cancer, while in US there are around 45,000 deaths every year. Every 1 in 8 men will get prostate cancer in UK. While statistics show where my practice is based in Dorset, we get 1 in 6 men who will get prostate cancer. So maybe it's geographical, or maybe it's the diet. We get some very good Dorset beef, a lot of cattle and grazing grounds here. So, or a lot of elderly population in Dorset, people moving from London and other areas to live in countryside. Again, in Europe, most common cancer in Europe for males, and third most common cancer overall. So I will skip this stats in from Europe. And then again, briefly, risk factors are age, family history, or any of your siblings or dad or uncles, race. Prostate cancer, if it's there, it is more aggressive in Afro-Caribbean population as compared to Caucasians, or even Southeast Asia, less prevalent. Maybe it's to do with diet, because the more vegetable diet in Southeast Asia. And it's not an old man disease. Now we come across a lot of younger patients who are diagnosed with prostate cancer in their 40s. There's the symptoms, LUTs, which are the frequency, urgency, hematuria, painful ejaculation. And moving on, not this prostate cancer is called silent killer. So not everyone will have symptoms. Sometimes no symptoms, and it's just diagnosed with screening PSA. So we diagnose it with DRE, PSA, and there are other markers like PSA3 and different other new PHI, ERG, and multiparametric MRI is the gold standard now, where we do gadolinium enhanced multiparametric MRI, and which shows pyrite 3 lesions or abnormality, which we recommend target biopsies. And the other diagnosis, briefly, we do bone scans, and then PET scan, and with the PET, choline PET or fluoride, but the PSMA PET is the gold standard, high sensitivity and specificity than the bone scan. And okay. Now moving on to the EUA guidelines for screening. So all men over 50, but the one with a family history should be screened at year 45. Okay, so I'll skip this busy slide because we are going into the management. That's our objective. We should be screened, well-informed men should be offered screening, and skip this. Moving on to, we'll skip this. And these are the age-specific ranges, 40 to 50 is up to 2, and 50 to 60 up to 3 is normal, 60 to 74, and over 70 up to 6 PSA is normal. So recommendations are with whenever there is like a raised age-specific PSA, then we advise an MRI scan, and then if MRI shows lesion pyrite 3 or above, then we recommend biopsies. And this is the flow chart which we follow in our hospital. So when the patients are referred with a raised PSA, then they're offered age-specific PSA, and we exclude UTI, and then they're offered MRI scan, And with the MRI scan, if there's an abnormality, then they are offered. Previously, we used to do transrectal biopsies, but not anymore. Everybody gets transperineal biopsies, as it's safer, a more diagnostic yield, and a less risk of infection if you're doing transrectal biopsies. And then the biopsies are reviewed in our multidisciplinary team meeting, and then we make a plan regarding, we recommend what is best according to their age, Gleason grade, comorbidities, where they're suitable for surgery, robotic surgery, or brachytherapy, or external beam radiotherapy, or just active surveillance or watchful waiting. So this slide is regarding truss and biopsies, which we don't perform anymore due to the risks of infection and less yield. So yeah, I'll skip that. We do transperineal template biopsies. Every patient gets transperineal. And further one, that's our technique where we biopsy every 5 millimeter, every 5 millimeter of the prostate gets biopsied. And then this is our Dorchester. There's a template map. We get the image on screen where we know exactly where biopsy is positive, what is the Gleason score, what is how much percentage is involved, and then we plan surgery accordingly. If you look at this slide, his patient has got more aggressive cancer on the right side. So this patient was offered wide excision on the right side. There was only Gleason 6 on the left side, so he was offered no spinning on the left side. So this next one is MRI fusion biopsy, where MRI scan. If it's a very big prostate, we only target the lesion where the pyrite abnormality is, rather than sampling the rest of the prostate. It saves multiple biopsies. You can target the lesion, but you need to have a software where you can have this MRI superimposed on your transperineal biopsy screen. Then the Gleason grade, I'll skip, you all know this. And then we go on to, this Demico risk stratification, that low risk process, which are less than 10 nanogram per ml, and its Gleason score 7 or less, and its localized cancer T1 or T2. Intermediate risk cancer, the PSA is from 10 to 20 nanogram per ml, and Gleason score 7. T2B, both lobes involved. High risk cancer or PSA over 20, Gleason above 7, which is 8, 9, and 10, grade 4 or 5, and this T2C cancers, both lobes involved. Next, and then we are locally advanced, where it's T3, where the cancer has breached the capsule, and along with also their local lymph nodes, pelvic lymph nodes are involved. So nodal imaging is performed with multiparametric MRI scan, can show up nodes, and we also offer a CT in more aggressive cancer and chest, abdomen, pelvis, where we want to see para-aortic nodes involvement. So if the node is larger than 8 millimeter in pelvis and greater than 10 millimeter in abdomen, they're considered malignant. Then we do choline PET or PSMA PET scan. Again, I said a higher sensitivity than multiparametric MRI or CT scan. But again, PSMA PET, if the node is less than 5 millimeter, then can be missed. So we can't see if the node is avid. Now, this important slide, that's what we are discussing, mainly targeting the treatment for localized or locally advanced prostate cancer. So locally, if we've got a low Gleason cancer, Gleason 6, PSA is under 10, we can offer active surveillance that we monitor PSA and regular, like every 6 months interval. And if there is a rise in PSA, then the patient is offered an MRI scan. And if MRI scan shows abnormality, then we offer repeat biopsies of the prostate. And then the other options are that if the patients have got intermediate or high grade cancer, then they are candidates for external beam radiotherapy, then IMRT, intensity modulated radiotherapy. They can have brachytherapy if their prostate is less than 60 centimeter and they don't have LUTs, or HIFU, which we don't offer. I used to offer HIFU, but not anymore since robotics has kicked in. But where it's T1 cancer localized on one side, low grade, they can have high intensity focused ultrasound to treat their cancer. And then move on, go to offer open surgery. And then 10 years ago, we used to offer keyhole surgery, laparoscopic radical prostatectomies, but now we have moved on to robotically assisted radical prostatectomy, which is the gold standard. And then we've got other treatments which can have cryotherapy, and then you can have hormones therapy to inhibit their growth. And then we have got newer medication, which mainly they are for metastatic, which we are not addressing today. We are in unlocalized prostate cancer. And then there is this thing between what's active surveillance and what's watchful waiting. So again, if the patients are young, then we have to regularly follow them up every 6 month PSA and repeat MRI scans in a year time if the PSA is going up, and repeat biopsies. So this is for younger patients. So this is called active surveillance. While in elderly patients who are over 80, who won't warrant any radical treatment, we offer them watchful waiting. That's if their life expectancy is less than 10 years. And then we can set a target that you don't have to have that PSA monitored that regularly, but yearly PSA. And if the PSA, let's say, goes over 20, then we empirically treat them with hormone therapy. Then again, this slide is regarding comparison of open radical prostatectomy to laparoscopic or minimally invasive radical prostatectomy. Obviously, lap prostatectomy was slightly superior than open radical prostatectomy, but robotic prostatectomy has virtually replaced both open and laparoscopic prostatectomy in the West, where the robotic facilities are available. And this slide is regarding IMRT with intensity modulated radiation therapy, where this is high-grade cancer with androgen deprivation for 6 months to 3 years, depending upon the PSA and the grade of cancer. Then we move on to brachytherapy treatments, which are LDR, low dose rate brachytherapy with different radioactive seeds. We use iodine 125 here, and their eligibility criteria are that their PSA, the prostate volume should be for brachytherapy less than 50 centimeters. You can't offer it for very large prostates. And then they should have their IPSS score less than 12, so less than 12, and their flow rate should be over 15. If they're obstructed, and if you offer them brachytherapy, there's a risk they go into retention. And then we have got high dose rate HDR using iridium 192. And radioactive. This is for high grade cancer, and you can even offer for T3 cancers. And then this is the slide for brachytherapy implants. You can see it, moderate side prostate, radioactive seeds in both lobes. This slide is for a high intensity focused ultrasound. You can see there's a probe in the rectum, and this is a high intensity ultrasound is being emitted, and this causes heat effect and subsequent apoptosis due to heat energy. And if you, sorry, yeah, so yeah, I'm not offering that. We used to offer it here at our institute, but not anymore because most of the patients are now for robotic surgery. The advantages are a simple procedure, minimally invasive, better technique, reduced bleeding, less painful, smaller scar, faster healing, and decrease hospital stay. They go stay overnight, go home the next day. And you can see as compared to the big scar with open prostatectomy, there are only 4 small holes for the robotic ports, 2 on each side, and then an umbilical scar where we remove the prostate. And that's where the camera is, robotic camera is put in. And then, so the surgical outcomes are enhanced because there is 3D imaging, which is magnified. And again, we use controlled abdominal insufflation with carbon dioxide gas. The pressure, intra-abdominal pressure doesn't go very high. So that's why the outcomes are so much better. Patient feels so much better. And we use AeroSeal, which is computer-controlled pressures. And you see this camera, this is a 3D camera where you can see very good images, and especially it's very advantageous for suturing, etc. You can see with the robot, you can wrist, if you're doing open surgery or laparoscopic, you can turn your instrument to 180 degree, that's the wrist. But with the robot, you can turn it to 360 degrees. There's no limitation. So the suturing is so much better. And then you can have 3D and then it's 10 degree zoom, so better pictures. You can see the blood vessel better and you can do diathermy. And then you can see there's a finger console and which helps the surgeon dexterity, precision, especially while you're doing nerve sparing. And that's the setup, the console, surgeon sitting, and this be the patient. And the next thing would be like teleoperating, where you can remotely operate from another continent. So these are different. I'll skip through it. Robot, starting from basic Da Vinci robot to X model, and that will skip these. And then there is different now papers being published that robotic surgery is most cost effective, although the cost of the equipment is large, but then you save on the bed and then subsequent admission, less blood transfusion. So I'll skip these slides here that a lot of, slowly the laparoscopic prostatectomy has gone out and its robotic prostatectomy has taken over. So same in Europe, you can see there are robotic centers now all over the world. I think one in Karachi as well. So I'll skip these nice guidelines. So and a few more slides. That's a picture of Stanford University where I was trained in robotic surgery, where I did my fellowship in 1996. And that's I'll skip this. This is my robotic theater setup. And in terms of time, I'll go to the next slide. That's the port placement for robotic surgery. And then that's we are docking the robot briefly. You see the robot is being connected to the system. And then you can see from here that further, that's how I'm sitting on the console. And what I'm doing there is being replicated in the robotic arms for the patient. So, yeah, so a little bit you can see how things are being done. So that's my finger movements. Yeah. So this is Professor Atar Rahman, who is the president of your PAUS. He was visiting our theater and he was doing this recording. And you can see on the screen that that's being pre-prostatic fat is being removed. So it's very precise. And so moving on quickly, I'll skip this in terms of time and going. Yeah, so you can see a bit further. Again, Professor Ataraman wants to show that 3D image, what I see in 3D. So it is brilliant picture, you can see. Okay, so skipping that, and that's, you can see the endpoint, the anastomosis, beautiful watertight anastomosis, evenly spaced suture. So that's my 20 minutes. So I'll stop here. And we have published our work. We have got our videos, our techniques presented in EAU and European robotic meetings. And we have got a lot of awards for our work. Thank you very much.
Thank you very much, Mr. Naveed Afzal. It was very comprehensive.
You can take questions.
So I don't see anything in the chat box. Fine. I think everything is perfect and clear on local and locally advanced prostate cancer, various management option. So without any further time loss, because we are late by a few minutes, may I invite Dr. Zubair Chima, consultant urologist in Shaukat Khanum Hospital, Lahore, who is going to talk about the technical aspects of partial nephrectomy. And this is following in our focus of prostate and kidney cancer for this evening. So Dr. Chima.
Thank you very much. Assalamu alaikum, Dr. Hamad. Once again, I hope you can hear me and the rest of the audience.
Yes, you can, sir.
Okay, I will share the screen now. And partial nephrectomy, here it is. Can you see the slides now? I think I've learned how to share it by now. Okay, so again, thank you very much, everybody, for asking me to give this talk on the technical point of the partial nephrectomy. So what I've done for the purpose of this talk, especially for the benefit of the trainees, there are a few slides which I'm going to talk about, and then I will show you a video which will show you the different steps of the partial nephrectomy, and hopefully audience will find it useful. So in terms of the technical points, there could be a few points before we decide on any patient embarking on the partial nephrectomy, some during the surgery and obviously some post-operatively. So we'll try to touch them. So the first question which comes into our mind, why partial nephrectomy? Why do we need to do that? And I'm sure I probably missed the initial part of the meeting, but plenty has been discussed in terms of the evidence which is available in terms of achieving the goals by offering patients the partial nephrectomy or the minimally nephron-sparing surgery. So the main idea is to preserve the renal function, but does it also help with the overall survival, cancer-specific survival, or prevention of the cardiovascular events? These are the few bullet points which come into our mind when we try to offer partial nephrectomy to someone. And there's plenty of evidence available in literature. Although the suggestions are that it doesn't really much affect the overall or the cancer-specific survival, but definitely the preservation of the renal function and the prevention of the cardiovascular events, especially in the younger patients, younger cohort of the patients, it is very helpful. So if we look at the EAU guidelines, there's a level 1B evidence that the oncological outcomes in terms of disease-specific survival following partial nephrectomy equals radical nephrectomy. However, offer partial nephrectomy to patients with the T1 tumors. Okay, so we have to select our patients carefully. So who are those patients? Another technical point. So younger patients. Now what's happening, what we call as victims of the modern imaging technique, a lot of small renal masses are being picked up in a younger population who are getting investigated for other things, and obviously we are duty bound to do something about them, especially if we're suspecting cancer. So younger patients are one. Patients with who got some comorbidities like diabetes, hypertension, who may well be fine now, but they have got risk factors to deteriorate their renal function down the line. So if they are fit enough to sustain a partial nephrectomy, they are the one who should be offered bilateral disease, and single functioning kidney being the other ones. So once we have decided that, okay, we've got a patient, he's got a lesion which is amenable to the partial nephrectomy, what next? What next technical point? And that I think is when you are doing your pre-procedure preparation imaging. It is very vital to really be prepared what you're going to deal with on the day of the surgery, so that there are no surprises. And there are modern imaging available in terms of CT, MRI. Make sure we've got angiographic phase so that we know the vascular anatomy of the kidney. So there are no surprises if there's a one artery or more than one artery. There are 3D imaging reconstruction available, and even the 3D models being used in the West before offering them partial nephrectomy. So have a look on these scans on the top, beautiful scans showing exactly which vessel is supplying where. And you can even do the selective clamping of these vessels if need to be. Again, 3D images here and some 3D printing, which is getting popular in the West. So make sure we've got the right imaging available. We have done our homework before going in. So having done that, there are different nephrometry scores. So what do these nephrometry scores do? I mean, I think the one which you're seeing on the slide is called the renal score. It predicts the complexity of the case. So all you are looking at the radius of the lesion, how big it is, and then you score it accordingly. Is it exophytic? Like you see here, the part here, more than 50% exophytic or less than 50% exophytic and more endophytic. Again, tells you if it's more endophytic, you're probably not going to see anything on the surface. So do you have a ultrasound probe available, or a friendly radiologist who can come and help you and mark the lesion for you if it's purely intrarenal? Is the lesion anterior, posterior, and location in terms of the borderline. So then you score it and you get a low, medium, or high score. So it predicts what kind of difficulty you're going to embark on the day of the surgery. So that's another technical point. In terms of the surgical approaches, yes, you can do it open laparoscopic, both transperitoneal and retroperitoneal, depends how you have been trained, what's the complexity of the case. As far as the laparoscopic surgery is concerned, robotic is getting popular, and especially in terms of the partial nephrectomy, robotic is actually very helpful. You see the 3D images, and the stitching is much easier. Hand assistance has been used in many countries, and pure laparoscopic, which probably is diminishing now with the introduction of the robot in the West. So it all depends what you have been trained and what facilities are available. But more so now, the more options are either open or robotic in majority of the countries. So when you're doing the procedure, what are you trying to achieve at the end of the day? What is called as achieving the trifecta. Yeah, you want to have a cancer control, you want to have a negative surgical margin. So you need to select your case accordingly, that the tumor is resectable. In terms of the partial nephrectomy, you want to preserve the renal function, and that depends on the ischemia time. More recently now, it's the warm ischemia which is used. People have used the cold ischemia where they cool down the kidney for 10 minutes or so with the ice slush, and that gives them more time to resect and stitch the kidney bed. And however, generally less than 30 minutes, around 25 minutes is generally acceptable. And then also you don't want to have any intra or post-operative complications. So if you achieve all those three, you're achieving trifecta. So in terms of the steps involved, and I'm just going to briefly name them, and then I'll show you them when I show you the video. Obviously, you need to have access, either it's open access or laparoscopic access. The bowel mobilization is the same as you do in the radical nephrectomy. You do the hilum dissection, you take control of it, you do kidney mobilization, especially if it's needed in an open case. You want to really lift the kidney out of the wound, tumor identification, clamp the vessels, tumor resection, renal referent closure, and I will talk about that when I show you the video, and I think it will be more helpful there. So before I show you that, I've got some pictures here of our cases in the past. to give you some idea how it looks like, and I'm sure most of you probably have seen it. So here you can see on the right, on my left side, so hilum has been taken control of, kidneys under the hand, and that's probably is the ureter. The kidney has been lifted up as it is mobilized all around, and the reason we do it, mobilize it all around, is because then it comes up, especially if it's a deep patient, and stitching becomes easier. And you can see the lesion there with a bit of a fat, which we leave it on the top of the lesion. Next, on this side, you can see, I think the clamp has been applied, and with the help of the diathermy or the scissors, you resect wider to the tumor or enucleate it. That's what the bed looks like, where you do the renography, and then you put the big vical stitches across the meat of the kidney, and you can put a Surgicel blister in there and take the clamps off, and that's how it will look like. I will show you in our case how it looked there. So this is our patient. I think he was in his late 50s, and he presented to us with this approximately, I think, 3 centimeters. So left-sided lower polar friendly location wise lesion. Majority of it was exophytic, and you can see it in the sagittal end and the axial scan. I think his BMI was around 37 or so. So he was a bit obese. So we offered him laparoscopic partial nephrectomy, because I thought we'll be able to do it, seeing its location seems pretty friendly. Okay, so what I'm going to show now you is the video and take you through the steps of it. So I'll press this new share and click on this. Hopefully it will work. Can you see the video picture now? I hope you can. Yeah, okay, brilliant. So I'm going to play it and then probably skip some parts of it so that we don't overrun in terms of the time as well. So here, so the initial steps have been done. The positioning is the same, which we discussed day before yesterday for the lap radical nephrectomy or adrenalectomy. Both sides are the same, which I showed you the day before. So here you see the colon has been mobilized immediately already. There's the psoas, kidney has been lifted off the psoas along with the ureter and the gonadal vessels, and probably here was the gonadal vessel coming in. Since it was coming in my way, I probably decided to put a clip on it and get rid of it. And this is the renal vein. In this particular case, if I remember, the renal artery was right behind the vein, a bit superiorly. So what I'm trying to do now is to gently tease away the fat above the renal vein to make a window there. So that at least I've got a control of the hilum. So initially I've tried it with the ligashore. Sometimes those jars work and it helps, but sometimes if there's a bit of a tough tissue, you need a bit of a hook to make a window there, and then bring your ligashore or Maryland to create the window there. So just gently in the line of the vessel. So bear in mind you're working on hilum, so with all attention. So section, bit of a rubbing with the peanut to get this fat. This patient has a reasonable amount of fat on this side of the hilum. So if I take you a bit forward on this video to show you. Right, okay, so again, see, I probably created a window on the top of the vein already, and there's a window down, and what I'm trying to do is to dissect at the back of the vein to isolate that artery, and trying to work it out where it is, where I can feel the pulse, see the pulsations, but I can't get the glimpse of it. So I'm still working on it. So when I was not having much luck on that, because it was right behind the vein, I think what I decided that, okay, fine. So I need to get this vein away from me somehow. So I created a window across the vein very gently, giving it its due respect. And I thought I will put a sloop around it. So that window has been created there. And then I'm bringing a sloop. So what I'm going to do, I'm going to sloop the vein, and then with my left hand, I will pull the vein to the left side so that I can get better access to the back of the vein. So see, I've gently held it. Now I can access the back much more confidently and do my dissection down there to isolate the artery. So the idea is you isolate the hilum, you identify the vein, identify the artery. Doesn't matter if you're doing it robotic, you're doing it laparoscopic or open, you need to have a control of the hilum, because obviously we all consent these patients at the end of the day before starting the procedure for radical nephrectomy. So we need to have a control of this area. So when you are doing it open, yes, you can only clamp the artery, or you can clamp the hilum, artery, and the vein together. But when we are doing it robotic or laparoscopic, we tend to isolate the artery and clamp the artery only. So I think I just about probably saw the glimpse of the artery down there in that window, which I will show you in a second again. Yeah, so I can see probably the, yeah, there it is. There's the artery coming up. Now I know where it is. So I'm going to get rid of the tissue around it. So that gentle teasing with a peanut swab, with a bit of a suction helps. Sometimes a bit of irrigation helps to delineate the tissue a bit more. Continuous, just being patient and taking your time, because this is a important step. So I know the artery is down there, so I can get rid of this tissue there. So that's what I'm doing. So hilum dissection is a very, very important step. So let's move a bit forward to see if we have got control of this artery in a couple of minutes time, I think somewhere here. So yes, here I'm probably putting a sloop around the artery now. So the idea to put, you may say why I need to put a sloop around the artery, because once I've identified it, I'll put a sloop around it so that I've got a control of it. And plus, after doing this step, I'm going to go back to the kidney, right? And then I'm going to isolate the tumor there and mark the tumor there and get it ready for resection. So when it's ready, I want to come back to this area, and I don't want to start digging into this place where there may be a bit of a ooze of blood and try to find the artery again. So once I've got the sloop around it, all I need to do is to pull the sloop and the artery will come in front of me. Oh, so I think, so that's there. Yeah, okay. So that sloop is, so these, both of these things are now in my control. So once I've done that, so in this area, I have already taken the fat away from the lean. You can see the lean down there. Kidney has been mobilized laterally because part of this tumor was going posteriorly. What I'm all doing with the help of the scissors attached with the diathermy, I'm marking my area, probably 4 to 5 millimeters away from where I think the edge of the tumor is. I'm going to mark it all around it. So this will be my marking step, and then I'll be ready to resect on it. The reason I do the marking is so that when it starts oozing, which it will invariably, then I know at least where my planes are, since I have got a lesser control compared to the open surgery. So I've done the marking down there. I've moved the clip forward, and this is a bulldog clamp, which is in my hand, and I'm coming and trying to put it on the artery. So that's why I put these rubber sloops, so that I can handle the artery while I'm putting the clamps on. Okay, so this clamp is going in, apply it. Probably I'm not happy because I can see the clamp has gone through that orange bit. So I'm not happy that it now, I've readjusted it, gone back and seen with my camera that the tip is across it. So now the clock starts. Now I shout to somebody in the theater to start the clock so that at least I know in terms of the time, how much time I've got. And then I start resecting it with the diathermy and scissors. So I use both energy as well as the cutting of the scissor. Now people do different ways. My way of keeping a track of the time, which is very vital, why I'm concentrating here, is to nominate somebody in theater who lets me know every 5 minutes that 5 minutes are over, 10 minutes are over, and 15 minutes are over. Okay, so that's I've got my left hand here, which is helping me to press the kidney on, and somebody is coming in with the suction, which will be using the suction to suck the blood and also to retract the tumor. Ideally, it's if I've got a chunky bit of a fat on the top of the tumor here, that's very handy to hold. I couldn't get much on this particular case to hold on to, and it just peeled off, so which didn't help. But I'm afraid that's how the cases will be. One day you'll get a good fat, one day you won't get a good fat to cut onto that. So that resection carries on. So not much ooze at the moment, but it will happen. As I knew in this case, there was a bit of a ooze, but that was most of it was venous, I think. So I asked my assistant to help me with that, push it so that I can see into that corner. So as it's starting to do these cases, usually on the left side, the lower pole lesions are the one which one should go for. And as I always say, and always try to follow that advice as well. Start with the simpler cases, make a cohort of that, and only then later on take the challenges cases, and that's a message in that as well. So I'm just going to move it a bit forward so that we can see the stitching bit within the time. So that section is coming now. You can see a bit of the ooze coming down. So I'm continuing cutting with my scissors. You may think that I'm probably going to the tumor, but that's not the case. I can see the healthy, where's my cursor gone? Healthy tissue there, and soon you will see the edge of the tumor. Then I will readjust myself. And if it does happen that you think that you have gone into tumor inadvertently, then you readjust yourself. So this is a healthy tissue. This is the edge of the tumor here. So it kind of enucleates here as well. So that resection carry-ons there. Attached from the sides. So now you can see probably better here. So yeah, so the healthy tissue here, and it starts enucleating. So it's a combination of enucleation and resection. If you can, in the right plane, then you're okay. And it is pretty stressful, especially laparoscopically. It's pretty stressful because you don't have that tactile feel, and plus the control is not as good as in open, or even in robotic. You've got a better control and better maneuverability. So that's out there. So tumors out there. So usually I park my stitches. So the other thing which I do, I park my stitches already in the abdominal cavity so that I don't have to come out. So I usually hook them up with the abdominal wall from the inside. So this is the rhinopharyngea stitch. So this is a V-lock stitch. So the reason I like it is because you can see this is braided. So when you take it through the meat of the kidney at the renal bed, when you're doing the rhinopharyngea, it doesn't slips back like the monocryl does. You can also use monocryl. So these are the deep stitches in the meat of the kidney, which will take care of the oozers. Some people, so I start from the one end of the kidney. I've taken the outer stitch from outside to inside. At the end of my stitch was a hemolock. I don't know if you noticed, if somebody noticed it or not, or maybe it wasn't visible, and that's why it gets tacked. It gets tacked to the kidney. So I'm going deep into the meat of the kidney, coming out, and I'm going to start from one end, and I'm going to come towards the second end. So this will be the renal bed, and this is mainly to control the bleeders, and if there's a small opening of the pelvic calcium system, not in this case particularly because this wasn't that deep a lesion. So here I come again, hold it, and then give traction from the other side. So this is going to carry on till this end. I'm just going to move it a bit forward again for the purpose of the time. So you can see there's a spot of the blood on the camera, but since I can see, I rather continue because time is the essence here. As the clock is ticking away, your heart kind of starts sinking a bit, but you carry on, keeping yourself calm. And So I'm probably towards the end of this renal refi bed stage. Some people do it, especially in robotic, if there's a bigger defect, they do it twice, starting from one end, coming to the other end, and then from starting from this end, going to this end, other end. But in this particular case, I don't think that was needed. So once I've done that, I will clip it here with the Hemolock, and then I've got two mattress stitches, which are two Vicryl stitches, I think Vicryl 1 stitches, which are joined together at the end with the Hemolock, right? So they're like a mattress stitches. So one of them I will apply there, and one of them I will apply here. And these are like a big, thick stitches, which you apply through the meat of the kidney, and you usually put the surgical booster, and then you tie them on the top of it. So they act like that. And they act like they also control the bleeding from the edges of the kidney. So this is so I'm going to push and pull the string and push the Hemolock down there, leave it there. So here you can see, I think I applied the one mattress stitch already there, and you can see that that was applied there. So this is the second mattress stitch which is coming. It's a nice deep stitch. So that's a Vicryl 1 coming from here, and then again going in. And this is going to give attention to, going to give these two edges together. So these two stitches are joined together with the Hemolock here. So here is the Hemolock, which is clipped to hold these two. This is the second needle, which is again the end of it is joined to that Hemolock. So it will act like a mattress. So again, coming down here. And taking the needle out on the other side, giving it due traction, and then applying two Hemolocks here with the traction. So again, this is what is tightening it. And then if you're, sometimes these stitches can cut through if you're not deep enough. So yeah, it's better get it deep in first instance. So pulling the string and pushing the Hemolock down, as you see here like this, so that it's tight enough. Going to the top one where I haven't applied, or probably have applied, I'm just going to tighten it a bit probably. So once I've applied these stitches, I will quickly go down to take my, I will put probably a bit of swab there, just getting ready if there's any small loose, it can look after it. And then go back to the area to take the bulldog clamp off. So coming down there again, I can see it there. Take it off, drop it down there, and come back to the top. So I will probably, I've got this swab there. I'll probably press it for a couple of minutes, just so that if there's a little ooze, at least there's a pressure which helps it. No harm in doing that. Again, gonna move it forward a bit. So kidney, as you can see, looks pink. The clamps are already off. So swab is gonna come off in a second. So I've taken the swab off, and what I'm then put is Avicel or Flow-Seal, which is a hemostatic agent, fibrin. It comes in this foamy and liquid form, and that's really good, very good hemostatic agent, which will, if there's any little ooze, that will take care of it. Okay, so I think that brings to the end of this part of the video. So again, I probably have tried to show you the steps which are involved in that, and more or less there are similar things, which are similar steps which are involved in different types. Either you're doing it open or you are doing it laparoscopic or robotic. So this Surgicel is, Flow-Seal is going to stay there, and then I will retrieve the specimen. I'll put a drain probably next to it, and if I've got enough fat around the kidney, I will mobilize it and stitch it with a couple of anchoring stitches. So I'll stop the video there, and post-operatively, right, okay, post-operatively, I usually monitor these patients in a high dependency care, especially for the first 24 hours, because I'm always worried about any risk of bleeding, so that at least I can get a better monitoring there. So that's it from this video presentation point of view. I'm happy to take any questions or answer any queries. I mean, this is a topic where you can have a longer chat, you can talk a lot, but in this time, I think I was only able to show this bit. Dr. Hamad, are there any questions or anything, any comments from your side?
Well, so far there is a comment about while taking stitch depth and margins of stitch, is there any cutoff value, or is it depends on the personal preference? So probably what is being asked is that how do you determine how deep you go when you're taking the initial bit?
So when we're doing the renal referee stitches, the renal bed stitches, you really need to the needle which we use is the stitch we use is a 3/0 usually, or sometimes 4/0. So it's not that big a needle. So you need to really go deep, the whole depth of the needle, to take a better control of the small oozers. If you see any open pelvic calcium system, you can stitch it that way as well. So yes, deep stitches are better.
Right. I think there are no further questions. So with this wonderful demonstration of lap partial nephrectomy and technical aspects, thank you very much for covering it in a short span of time. So I think we come to the end of this evening's program. Tomorrow we have 1 to 4 p.m. rotation at Indus Hospital. And Dr. Zaidi and his team is going to demonstrate pediatric urology of various pathologies related to and operative procedures of pediatric urology. In the evening at 5:30 p.m., we have urolithiasis and urethral stricture. So we're going to have a couple of presentations, but two interesting case discussions, one on urolithiasis and the other one on urethral stricture with our panel of experts. And so hope to see you again tomorrow, 1 p.m. for Indus Hospital Pediatric Urology rotation and 5:30 p.m. for the conceptual base of urology course on urolithiasis and urethral stricture. So with this, I thank all the presenter for this evening for the wonderful work, and thank you very much and have a very good evening. Allah Hafiz.
Thank you very much. Allah Hafiz.